Connected by purpose, driven by passion. This is Children's Healthcare Canada's Spark Live webinar series.
Children's Healthcare Canada would like to thank the following Keystone funding partners for their ongoing contributions that support all of our programs and activities. The Stollery Children's Hospital Foundation, BC Children's Hospital Foundation, the Children's Hospital at London Health Sciences Centre, the Alberta Children's Hospital Foundation, the Children's Hospital of Eastern Ontario, and Holland Bloorview Kids Rehabilitation Hospital. We would also like to thank the organizations that provide funding for our knowledge translation activities, which includes this Spark Live webinar series, the Spark Conversations blog, and the Knowledge Exchange Network. To learn more about Children's Healthcare Canada, you can go to our website, follow us on Twitter or Facebook, or you can sign up for our weekly Spark newsletter at childrenshealthcarecanada.ca/email, where you will learn about upcoming events, read the latest posts from our blog, and other exciting news and events from across the child and youth healthcare community.
Hello everyone, and welcome to Children's Healthcare Canada's Spark Live webinar series. I'm Paula Robeson, your host for the next hour. Spark Live is where we gather each Wednesday to curate, convene, and showcase excellence and innovation from across the child and youth healthcare community, with our goal to spark conversation, ideas, and action. Since we're live, I want to remind everyone that while we don't take questions over the line, we welcome you to type your questions into the question box at any time. I'll check periodically for questions throughout the session, and so don't feel you have to wait until the end of the presentation before you start typing questions. Just go ahead, put them in as you think of them. I'd also like to let you all know about an event Children's Healthcare Canada is hosting in partnership with Alberta Children's Hospital and Alberta Health Services, being held in Calgary on April 22nd of this year. This specialized event, called All In, Creating Synergy in Pediatric Complex Care in Canada, will welcome over 200 administrators, frontline clinicians, parents, and families. The focus will be to showcase and share practices that we know are working to help support children with complex healthcare needs and their families. And registration is now open. I would like to welcome today our colleagues from Alberta Children's Hospital for rare diseases and the impact of the new genomic era of practice. 1 in 12 Canadians has a rare disease, and 2/3 of those with rare diseases are children. Recent advances in genomic technology and knowledge are reducing what is all too often a confusing and complicated diagnostic odyssey for many families. A rare disease diagnosis may help improve health outcomes by permitting early detection and prevention of associated morbidities, both in the affected patient as well as at-risk family members and future generations. As well, it can permit access to community supports, government funding, emergency precision therapies, and emerging research. I'm delighted to welcome our speakers today. Rachel Ferrier is a certified genetic counselor practicing at Alberta Children's Hospital in Calgary since 2005. And Leslie Colville-James received her master's in genetic counseling from McGill University in '96 and is American and Australian board certified. And her clinical practice has covered a range of clinical specialties in Canada, the US, and Australia. For those of you on Twitter, please tag us at Child Health Can and at AHS_media to any webinar related tweets you share today, and then go ahead and share away. And it's my pleasure now to pass the mic to Ray.
Thanks, Paula, and we'd like to thank you and the organizers of this webinar for giving us an opportunity to speak about something we're very passionate about. I don't see the slides yet. Perfect. So welcome, everybody. We'll just dive right in. So over the next 40 minutes or so, Leslie and I have quite a lot of content we'd like to cover. We plan to start with an overview of rare diseases, as well as a discussion of the diagnostic journey that many patients with rare diseases face, including the implications for family members. Next slide, please. The landscape of genomic testing has changed pretty significantly in the past decade, and we plan to spend a bit of time discussing some of the new challenges that come with advances in genomic technologies, as well as some strategies. We've also dedicated a bit of time to emerging therapies, which is a very exciting new frontier in precision medicine. And finally, we plan to close the webinar with a brief review of some of the relevant legislation and professional guidelines, especially as they pertain to testing in children, and offer you some closing thoughts regarding ethical and psychosocial challenges that may arise in the era of rapid genomic testing. We could probably deep dive a full 60 minutes into each of these topics, but our plan is to spend about 5 to 10 minutes on each and leave plenty of room for dialogue at the end. I know Paula mentioned that we can take questions throughout the webinar, and in the interest of time, we're thinking that we might sort of save time at the very end of the webinar to actually address the questions that you may have. So our learning objectives were circulated with the webinar announcement, and so we won't reiterate them here. And we'll just jump right in and start with an overview of rare diseases. So the definition of what constitutes a rare disease is actually different depending on what country you're in. And in general, it's considered in the ballpark of a condition that affects less than 1 in 2,500 people. For many ultra-rare diseases, there may only be 1 or a handful of people in the world who are known to be affected. It's currently estimated that there are probably anywhere from 7,000 to 10,000 different rare diseases. And so even though individually each one might be rare, as a group, they aren't actually that uncommon. It's estimated that perhaps about 1 in every 12 Canadians may be affected by a rare disease, which is over 3 million Canadians, or roughly the entire population of Toronto. Worldwide, that's about 300 million people, or the entire population of the United States. So if you think of rare diseases collectively, it turns out that they aren't so rare after all. And children are disproportionately affected by rare diseases. About 2/3 of Canadians with rare diseases are children. And a report from the European Conference on Rare Diseases reported that about 30% of kids with a rare disease will die under 5 years of age. For comparison, about 1 in 15 children are born with a rare disease, and that's a prevalence which is 100-fold greater than the incidence of childhood cancer. Most rare diseases are known or thought to have a genetic basis, and pretty much every genetic condition is considered a rare disease. People with rare diseases may face challenges that are different from those challenges experienced in more common medical conditions. Rare diseases are often chronic, they're complex, debilitating. They've been shown to produce significant medical, physical, psychological, emotional, and social consequences. Treatment may or may not exist, and usually there isn't a cure. Many rare diseases present an ongoing risk of death, and some are inevitably fatal. Due to their low prevalence, many healthcare professionals often have minimal knowledge of specific rare diseases. For the rarest conditions, the published literature might consist of a single report describing just a few individuals. Clinical expertise may be limited and fragmented across the country, and patients and families may have inadequate access to information and resources. So Leslie and I work as genetic counselors with the Clinical and Metabolic Genetics program that serves Southern Alberta. And these are just some pictures of some members of our team with some of our patients. It's our team's mission to identify an accurate diagnosis for all patients with rare genetic diseases, to promote access to precision therapies, and to engage, empower, and support patients and families. Demand for our services have skyrocketed in the past decade. And this is not unique to Calgary. It's a trend that's seen across clinical and metabolic genetic services nationwide. This increase in demand has not been met with an equivalent increase in resources, leading to growing wait times and further impeding access to diagnostics, therapy, and support for patients and families with rare diseases. This difficulty patients and families face when it comes to understanding the nature of the rare disease impacting them is sometimes referred to as a diagnostic odyssey. And I'll now turn things over to Leslie to discuss this further.
So I am just going to overview a little bit what a diagnostic, what the impact is of these diagnostic delays. So first of all, I guess it's important to understand the benefits of the diagnosis. Traditionally, we think of diagnosis being important as it guides management and treatment. But unlike infectious disease, in rare disease, treatments are often symptom-based, so you don't really need a diagnosis, right? Well, it turns out even when there is no cure, there are tremendous practical and psychological benefits to obtaining that final diagnosis. So much so, we have a specific term, the Diagnostic Odyssey. The Odyssey is one of Homer's great epic stories and describes Odysseus's long, strange trip home after the Trojan War, approximately 3,000 years ago. During Odysseus's 10-year journey, he and his men had to overcome divine and natural forces, from battering storms and winds to difficult encounters with Cyclops, the Lotus Eaters, cannibalistic Lystrogenes, the witch goddess Circe, and the rest. And they took a most circuitous route, bouncing all over the Mediterranean. I want you to compare that map with the next slide, which shows a similar map of the challenges patients face in obtaining a final diagnosis. On average, it takes about 7 years for families to obtain a final diagnosis for rare disease. That is, that time from the first emergence of symptoms to achieving a final diagnosis. And families report high levels of stress and anxiety and frustration at the time that takes. This is just a quote from one family who experienced that, where it took 9 years for them to obtain that diagnosis. So I guess the question is, why? Why does it take so long? Well, there are multiple reasons. It's often due to limitations in 3 interrelated areas, which are firstly limitations in our scientific knowledge. We can only recognize what we already know or have seen before, or have seen described by other clinicians. The second limitation is primarily in our testing technology, and that's where we perhaps made the greatest advances. The third limitation is in communication between healthcare providers, between individuals with rare disease, and limitations in our access to the knowledge that's out there. Historically, all these things played into the diagnostic delay. Ray will talk a little more in her next section about how some improvements in all of these areas is helping speed up this process. So traditionally, our genetic process has been labor intensive. We want to pull together everything, all the information that we can, to create as complete a picture as possible. We were restricted by limitations in our knowledge and technology available for testing. Just remember, up until about 10 years ago, we had to test genes one at a time in a serial fashion. I thought at this point it was worth giving you a brief overview of the timeline of our genetic advances. So in the 1950s, we first were able to describe the structure of DNA. And that was when we first were able to say exactly what the normal number of human chromosomes were. It took about 30 years before we could locate the first gene on the chromosomes, and only in the 1990s we began to be able to offer gene-based genetic testing. In the mid-1990s, microarray became available to detect variations in dosage at a resolution greater than the chromosome level. And as I already pointed out, multi-gene panel testing only really became available in about 2005. And whole exome sequencing, which is testing all the important coding parts of the genes, still only about 2% of the genome, became clinically available in the US in about 2015. Sorry, a little bit earlier. Whole genome research began only in 2008 and is still mostly available on a research basis in Canada. So just to sum it up, when there's traditionally no cure, diagnosis primarily helps with adjustment, helps with some idea of prognosis and inheritance, direct screening for known complications. Traditionally, we would follow patients in order to try to understand the natural history, and we would provide support to families, connecting families and connecting them with disease-specific support groups. Once you have a genetic diagnosis, we don't finish there. So there's this idea of the genetic cascade. It turns out in genetics that the patient is really only half the patient, and we also try to care for the families in the best way we can. This is what's known as the genetic cascade or cascade testing. So it's helping to support families through the implications of that initial diagnosis. The classic example of this kind of sequelae and the importance of the diagnostic testing is Down syndrome. All individuals with the condition have it because of an extra dose of the genes on chromosome 21. It most often occurs as trisomy, 3 free copies of chromosome 21 with a low chance of it recurring. But 5% of the time it occurs because of a rearrangement in the chromosome material, where one parent or the other has a copy of their 21 stuck to another chromosome. This is called a translocation. This can be passed down through families and can imply increased risk for other individuals in the family to develop, to have children with Down syndrome. Historically, we would try to predict genetic inheritance from the pedigree, even if we didn't have a clear diagnostic test to help us be sure. So this is just an example. Retinitis pigmentosa is a progressive degenerative vision condition. One of the first signs is night blindness. Almost 50% of cases, if you take a family history, look like this, with just one case and no other affected individuals in the family. There's consanguinity, relatedness in the parents, and that would suggest, that would make us in genetics excited about the possibility that this could be something that's recessive, as there's a higher chance of individuals that are descended from a common ancestor carrying the same genetic change. Once the newer technology became available and we were able to actually find the genetic cause, about 15% of these individuals have it because of change in an X-linked gene for retinitis pigmentosa. That would imply risks for the sisters of that individual to possibly be carriers who might be able to pass it on to their own sons. And about 11% of the time, it actually comes about because of a new dominant change, a new change in a dominant gene, and that would imply low risk for the other siblings in the family, but higher chances for his own children to develop it. So that kind of cascade testing decisions are made about who to test and when to test, when the optimum timing is, around the utility. So balancing what information are we going to gain and how is that going to change management versus what are the risks of or possibilities of harming the individual that you're considering testing. So one of the controversial ideas is whether or not to test child siblings. And I would say for conditions that are rare with for example, a high risk of sudden death, where you would have screening and preventive measures that may be put in place, it's perfectly appropriate to consider testing child siblings to know what their status is. It's also beneficial for those that are not at risk to not have to undergo that burdensome screening. But for adult onset conditions or like hereditary cancer syndromes, there's not going to be any change in management that occurs when that testing is done in childhood. It's not going to happen until adulthood. So we tend to defer our testing. It's always a process of balancing utility and risk. Traditionally, there were no cures. So knowing in advance if someone's going to, if a close relative or a child is going to be affected or if there's going to be a recurrence, was primarily to prepare for the birth of an affected child or to exercise reproductive management options. Autism or recessive conditions are only at risk to be passed on if both partners are carriers. So we traditionally started with cascade testing of siblings of the parent to see if they were carriers. If they weren't, we could stop there. If they were, potentially we could offer screening to the partner for that particular gene to see if they were also at risk. And then if both partners were going to be at risk, or if there was a high risk, we could offer things like pre-implantation genetic diagnosis with IVF or prenatal diagnosis, which is an invasive procedure with miscarriage risk. Some of the emerging options that are out there as a result of improvements to our testing technology, for example, universal preconception carrier screening has become an affordable option for some as multi-gene panels become technically possible. There's risks to testing large numbers of genes at once, including increased chances of a positive screen. Traditionally, carrier screening was for those at increased risk, such as family members of an affected child or ethnicities that were particularly high risk, such as Ashkenazi Jewish for Tay-Sachs. The perspective can be slightly different for these kinds of families where there is no history, so there's no familiarity with the condition. And sometimes we might say, if we're offering testing, does that imply value judgment about the condition itself? So it's very important to carefully counsel couples prior to this testing regarding the things that they may have to face if both members screen positive, regarding possible results and some of the decisions and options they may have. Another emerging sort of genomic option that's changing in this new era is non-invasive molecular testing or screening. This is testing or screening of fetal DNA in the maternal bloodstream. It can be done as a blood test from about 10 weeks of pregnancy. Because it's not invasive and there's no miscarriage risk, it's proven to be fairly popular. It's still a screening test though. And if someone screens positive for a condition, then there needs to be follow-up with invasive diagnostic testing to confirm. Initially, this has been offered for the trisomies, the common trisomies 13, 18, 21, and the sex chromosomes. But the technology is improving, and today it's possible and available in some places to detect common microdeletions, usually only offered in high-risk situations. And on the horizon, it's possible even for monogenic diagnosis, though it's definitely not standard of care yet. I'm going to pass over to Ray for a little more on the era of genomic medicine.
I'm glad you said that. I would have forgot to unmute my microphone. Thanks, Leslie. So this brings us to a section where we're going to cover sort of the practice of genomic medicine today. Leslie gave a great introduction into that, including some of the challenges that we sometimes encounter and some of the new strategies that we're employing. If you've ever attended a talk about advances in genomic testing, you've probably seen the graph that's on the next slide, which is intended to demonstrate the rapid decrease in cost of DNA sequencing over the last decade in reference to Moore's law, which is the straight line. Moore's law describes the trend we see in computer hardware that involves the doubling of compute power every 2 years. And in general, it's regarded that any technological improvement that keeps up with Moore's law is doing very well. And as you can see, beginning in 2008, DNA sequencing transitioned to next generation technologies that Leslie mentioned, and that just blew Moore's law out of the water. You'll notice that the y-axis is actually a logarithmic scale. So the cost of sequencing a human genome in 2001 was $100 million, while today it's about $1,000. So, today it's relatively straightforward and inexpensive to get a person's DNA sequence. Next slide, please. And for many families, accessing genomic sequencing has been the key to ending the diagnostic odyssey and arriving at the information, answers, and support that they've been looking for. But these technological advances don't always produce certain or expected findings. In this next section, we'd like to review some of those challenges and insights. So as Leslie outlined, families are seeking a diagnosis for a number of reasons. And historically, when a genetic diagnosis was made, it was possible to give patients and families general information about what to expect for the future based on our experience with other patients who are affected by the same condition. But today, large-scale genomic sequencing is discovering new disease-associated genes in some of our patients for the first time. And so, although we may have uncovered a diagnosis, we may still be limited in our ability to give families what they're looking for, to discuss what that means longer term, to offer targeted therapy, and to connect them with other patients and families with something similar. In contrast, sometimes genomic sequencing is finding that a patient who has eluded diagnosis for years actually may have a well-known and well-understood condition. However, their presentation may be atypical, so the approach of targeting single genes hasn't been successful. And I wanted to share this story. This is an amazing story that was recently published about a young girl named Ileona who developed a severe seizure disorder when she was 18 years old. She was otherwise developmentally normal, healthy. She was attending university. She was training to be a nurse. Over 3 years, she spent a total of 231 days in hospital. She tried 12 different anti-epileptic drugs, but her seizures were uncontrollable. She eventually ended up in an induced coma for 121 days as her care team searched for the cause of her condition and an effective therapy. Her doctors attempted targeted testing of every single gene they could possibly think of to figure out the cause of Ileona's seizure disorder, but they couldn't figure it out. So finally, they turned to whole exome sequencing, and they discovered that Ileona has a well-known condition that's called pyridoxine-dependent epilepsy. This was a shocking discovery, as this condition typically presents in infancy or even before birth, with these dramatic episodes of prolonged and intractable seizures. There is a late onset variety of this condition, but the presentation is still before 3 years of age. What's even more wonderful about this story is that pyridoxine-dependent epilepsy is treatable with large doses of vitamin B6. So once Ileona's care team discovered that her underlying diagnosis was this condition and started B6 therapy, her seizures disappeared. She now doesn't take any other seizure medications. She's been able to return to her university studies. Now, in both of these scenarios, our ability to interpret the genomic sequencing results hasn't been an issue. However, in practice, this may not be the case. We're often dealing with variants in genes where the significance of the variant is not known, or the significance of the gene isn't known. To give some perspective, we all have millions of differences or variants in how our genes are written. This is why we aren't all identical twins. The vast majority of genetic variants are completely harmless or benign. Occasionally, a variant in a gene actually does disrupt the gene's function and can lead to a genetic condition. So when a patient has genomic testing, you can potentially find millions of variants. The challenge is wading through the harmless variation to try and identify the single genetic difference that's responsible for a patient's features. For many patients, we find a variant in a gene that seems suspicious, but we lack sufficient evidence to conclusively know if we found the cause for the patient's features. This, understandably, can cause confusion and anxiety for patients and families, especially when an uncertain variant is in a gene that may carry with it a risk for additional health issues. Moreover, in shifting genetic testing from more targeted single gene approaches to broader ones that consider, large panels of genes or the whole genome, we're more often having to deal with findings that are completely unrelated to the reason we initiated the test in the first place, so-called incidental findings. Of course, incidental findings, they're not unique to genetics, they're throughout medicine, and many scenarios aren't new. For example, the incidental discovery of non-paternity is a classic ethical dilemma that can arise from genetic testing within a family. However, with new genomic technologies, the potential to uncover that a patient is at risk to develop a completely different condition is becoming more common. The output of genomic testing is filtered in such a way that we avoid a lot of incidental noise. But occasionally we may uncover that, for example, a little boy having investigations for a heart condition has a genomic structural difference that predicts he will have infertility as an adult, completely unrelated to his heart condition. Or a little girl with skeletal differences is at risk to develop multiple tumors under her skin as an adult, completely unrelated to her skeletal issues. These are two examples from Calgary. And because incidental findings are unanticipated and unpredictable, it's often difficult to prepare patients and families for these potential results. In contrast to incidental findings, which are, accidentally discovered, exome and genome sequencing has the power to generate what we call secondary findings. These are disease-causing variants in a list of 59 genes, as has been recommended by the American College of Medical Genetics and Genomics. So a patient with a disease-causing variant in one of these 59 genes would be at risk to develop an inherited cancer condition or potentially a lethal heart condition, or a handful of other conditions, all of which are considered medically actionable, which means they have treatments available that can prevent or significantly reduce associated morbidity or mortality. Although finding a disease-causing variant in one of these genes may be completely unrelated to the indication for testing, patients have the option of opting in to learning about secondary findings if they're undergoing whole exome or whole genome testing. It is worth noting that this practice is controversial, and although it is our current practice in Calgary, it is at odds with the Canadian guidelines from the Canadian College of Medical Genetics and Genomics, which advocates a more cautious and conservative approach. Direct-to-consumer genetic testing is also a relatively new challenge that has arisen due to the combination of low costs, increasing demand, and heightened interest and enthusiasm around accessing genomic technologies. Genomic testing is complex, and patients and families may not have the expertise to identify the appropriate testing platform for their particular context, or the experience to know what commercial laboratories can be trusted to generate meaningful results that meet, an acceptable level of quality. Unfortunately, we do have a number of examples of care gone wrong as a result of patients accessing genomic testing outside of a relationship with a knowledgeable clinician. There's one family that always comes to mind when I think of the pitfalls of direct-to-consumer testing. This family had a daughter with intellectual disability and epilepsy. Prior to whole exome sequencing being clinically available testing in Alberta, the family appreciated the possibility of this technology finding a genetic diagnosis for their daughter, and so they decided they wanted to private pay for the test. The cause for their daughter's intellectual disability and epilepsy wasn't found. However, the lab did report a secondary finding. They reported a pathogenic or disease-causing variant in a gene with the potential to cause a dangerous but treatable congenital heart condition that's called long QT syndrome. The family read about this condition. They understood that it's an inherited condition, so other people in the family presumably would be at risk, so they opted to private pay for testing for their other family members. And they discovered that both of the patient's brothers and the mother also had the gene. Now, long QT syndrome is potentially triggered by intense physical activity, and one of the patient's brothers was a competitive hockey player, which he really enjoyed. The family became very anxious about the risk for their children to develop a dangerous arrhythmia, and so they took their son out of hockey. Eventually, the family was referred to us. We looked at the whole exome sequencing report, and we immediately recognized that the variant in the long QT syndrome gene was not disease-causing. It was a well-recognized benign variant. No member of this family was at increased risk to develop long QT syndrome. But unfortunately, it was too late. Despite our reassuring counseling, the family continued to fear that people were at risk for arrhythmia. They continued to feel very anxious, and they decided it would be best for their son to give up hockey permanently. A final example of the type of complex result that can be uncovered by large-scale genomic testing is learning that the features in a patient are actually the result of more than one genetic condition. We find that multiple genetic diagnoses are responsible in about 2% of our patients who undergo a whole exome sequencing. In some families, this can have profound implications for how we understand the condition or conditions are running in the family. One example stands out in my mind of a family where there was a man who had been followed since childhood with the combined features of a very distinctive craniofacial appearance and significant intellectual disability. A unifying diagnosis had always been elusive. Eventually, his sister started a family, and her first child was a son who had the exact same craniofacial appearance as his uncle. Understandably, everybody was concerned that this meant the newborn had the same condition as his uncle, including the associated intellectual disability. The family was referred back to us, and we initiated whole exome sequencing for the uncle. And lo and behold, it turns out he has two different genetic conditions. He has an X-linked condition that causes the craniofacial differences, but no associated learning or developmental problems, and a new change in a gene that causes autosomal dominant intellectual disability. His nephew inherited the X-linked gene associated with the craniofacial differences, but did not inherit the intellectual disability gene, and so we would not expect him to have any associated difficulties with learning or development. So, despite the progress that we've made in discovering the underlying genes responsible for rare diseases affecting our patients, we believe that about 1/3 of rare genetic diseases still remain unsolved. As Leslie mentioned, communication between clinicians and researchers is key to solving rare diseases, and there are currently several strategies to tackle the remaining unsolved rare genetic diseases that are moving away from individual investigators and towards collaborative team approaches that pool resources and expertise and leverage shared knowledge platforms. And we just wanted to talk about a few that we're familiar with. So for example, in Canada, we have the Care for Rare initiative, which connects 21 patient care sites across the country to an expert team of clinicians, researchers, scientists, and bioinformaticians. Together, this super team has solved over 460 rare disease projects and provided a diagnosis to over 1,000 patients, both from Canada and around the world. Matchmaker Exchange is another example of a resource that supports gene discovery that our team searches and contributes to regularly. So through creation of a federated network of phenotype and genotype databases, clinicians can take their single case and search for other cases with similar physical features and genotypic profiles. And this platform has proven to be a powerful tool in building evidence for causality of a gene in some of our patients. So for example, we had a patient in Calgary with intellectual disability, distinctive facial features, and a pattern of skeletal and connective tissue abnormalities. In running whole exome sequencing, we identified a new variant in a gene that has not previously been described in the literature, a gene of uncertain significance. It was impossible to conclude from this limited information whether or not this gene and this variant in any way were connected to the patient's condition. But through Matchmaker Exchange, we were able to identify a clinician in Baltimore who also had a patient with an almost identical pattern of intellectual disability, facial features, and skeletal and connective tissue abnormalities, who also had a brand new change in the exact same gene. So this allowed us to work together to mount evidence that we had found the right gene. Something else that's rather exciting is in 2012, an international effort to standardize the terminology that's used to code genetic and rare diseases into health IT systems was initiated. So the International Consortium of Human Phenotype Terminologies was formed, and this was led by representatives from International Rare Disease Research Consortium as well as OrphanNet, which is an entity that maintains an online rare disease and orphan drug inventory, OMIM, which is an online catalog of single gene disorders, and HPO, which has become the de facto standard in describing human phenotypes. So representatives from all of these different coding systems came together and established a core set of consensus terms that can be used to describe rare diseases. And this not only supports, researchers and clinicians in being able to exchange data, but it also facilitates the use of informatics and search algorithms for biomedical literature meta-analyses. And the comprehensive and accurate documentation of phenotypic abnormalities in hospital information systems will support the visibility of rare diseases within health medical information systems. One enormously positive outcome of this consortium's work was that the set of standard rare disease nomenclature that they proposed actually served as a template for the 11th revision of the World Health Organization's International Classifications of Disease. This representation of rare diseases in ICD-11 will influence the way that physicians, hospital administrators, and national policymakers view rare diseases for decades to come. And as a final example, there are patient-led platforms like Rare Connect that not only allow patients to connect with other patients globally, but also securely connect with researchers and other organizations to share health information and enroll in research ethics board-approved studies. Rare Connect currently has over 45,000 members and over 180 disease-specific communities, including a community for people who don't have a diagnosis. So we've been focusing on how international collaboration is supporting our ability to arrive at a diagnosis for a patient. Goals of these collaborative efforts also include facilitating the development of precision therapies. And I'll turn things back over to Leslie to share some recent advances in this area.
Thank you, Ray. So I'm just going to change gears a little bit and talk about some of the emerging therapeutic options that are out there. Some are available currently, and others are in the works. So I'm going to talk primarily about a couple of examples of gene-based therapies, though there are other things coming up, such as cell-based or stem cell therapies, new pharmacological therapies, and even within the, I deal with some ophthalmologic inherited conditions, and there are some prosthetics being developed for retinal implants to allow people with late-stage vision, low vision, to recover vision. One of the examples I thought I would talk about is a condition that you may or may not be familiar with. It's a common for rare disease, congenital lethal condition in that. So there are 3 types of spinal muscular atrophy, which is the condition I'm going to talk about. They vary by the age of onset. They occur because of mistakes in the a protein called SMN1, which is important in muscle maintenance. So if there is a mistake in the gene, it means that the protein's not made properly, and because the muscle isn't being able to maintain properly, then it results in progressive muscle wasting, and the degree of harm to the gene or to the protein that's made dictates it may be part of what determines the different types, or how long it takes to present. There is a duplicate gene called SMN2, which has a different mistake in it, and is typically switched off or produces that protein at very, very low levels. A new medication, a gene-based medication called Spinraza, which is something called an antisense oligonucleotide drug, which means it's a drug that's involves, it's very specific to a specific place in the gene, and it allows the gene, that SMN2, the cell's machinery, to skip over that mistake that's innately in everybody's SMN2, and allow the gene to start producing SMN2. SMN2 protein can supplement the defective SMN1 and seems to be able to prolong muscle health. Now, I had a video, but I think given that we're pushed for time to get to the end of the diagnosis, I won't play this at this time. I'll move on and talk about my second and third examples, and then we'll, if we have time at the end and there's no questions, we can play some of those videos if people would like that. I wanted to talk about another exciting condition, rare condition, that has a new therapy coming. It's a condition called Leber congenital amaurosis, which is a rare 1 in 33 to 1 in 50,000 condition of early onset, progressive, reduced visual acuity, occurs congenitally, and one of the first signs is nystagmus, or shaking of the eyes. There are obviously many other causes for nystagmus. It's not the only cause. There is one gene called RP65, which is a genetic cause of a fraction of these individuals, and a new genetic therapy, gene therapy, applied directly to the retina has been developed. It's called Luxturna, and in 2017 it was approved for use by the FDA in the US. And there are now individuals receiving that gene therapy who experience significant improvement in their visual capabilities. It's not a cure, but it's significant improvement. And the last one is a condition, is a new drug called Trikafta, which is becoming available for treatment of cystic fibrosis. Cystic fibrosis, for those of you that may not be familiar with it, is a condition that it was historically considered lethal. It's a disorder of salt transport and results in thick mucus. And individuals with cystic fibrosis typically have respiratory disorders and pancreatic insufficiency. There's males with cystic fibrosis experience infertility. There have been many improvements in understanding the disease process and in treatment, which are certainly not all gene related, so that over the last little while, life expectancy was approximately 10 years of age in the 1960s. Today, there are individuals living in their on average, individuals will live till their sixth decade if they survive past that 10-year age range. And Trikafta is important because it's a medication that can be used by individuals who have delta F508 mutation. This is the most common mutation responsible for this condition. And it's effective for the majority of individuals. Unfortunately, it's available at a very high cost. So I'm going to pass back to Rachel for the last little bit.
Thanks, Leslie. Almost forgot to unmute again. In walking through these different case examples, Leslie and I have sort of alluded to a certain standard and attitudes that underpin how we approach offering testing. And we wanted to highlight some of the relevant Canadian legislation and guidelines that frame some of our conversations about genetic testing with families. First, there is a relevant law. It's called the Genetic Non-Discrimination Act, or GINA. And this law, it's relatively new, protects Canadians from having their genetic test results used in certain types of settings. These include by insurance companies, as well as certain types of federal employment. So for instance, this law prevents an insurance company from using the results of a person's genetic test against them. They can't use this information, for example, to set prices or premiums or decide who gets insurance. Also, certain employers can't use genetic test results, for example, in decisions about who to hire, who to fire, what work a person can or cannot do, and who to promote. Now, it's important to understand that insurance companies often make decisions based on a person's health history. So this includes their current symptoms or past history, whatever diagnoses they currently have. And so this law doesn't stop an insurance company from considering a person's health condition. And this includes a health condition that may have a genetic basis. So an insurance company can collect and make decisions about a person based on their symptoms of a genetic condition. They can't collect and make decisions in a healthy person who's had a genetic test result that indicates they're at risk to develop something in the future. That's the distinction. It's important to also keep in mind that insurance companies often ask about health history of close relatives, and this law doesn't stop insurers from making decisions based on a person's family history. And although this law does exist today, it's hard to know how it's going to hold up over time. GINA is currently being challenged in the Supreme Court of Canada as unconstitutional. It is certainly our hope that this law would remain in effect in the future. And then just one guideline that we wanted to highlight, and this is pertaining to genetic testing in children. And I've just it's a published paper, and I've just cut the recommendations out and pasted them here. But essentially, Leslie's already covered a lot of this in some of her examples about cascade testing in families. So as she pointed out, genetic testing in kids should only be considered if there's an immediate medical benefit. So the example she gave was of a child at risk for a congenital arrhythmia condition, where treatment would be initiated at birth for an at-risk child. And so genetic testing in children is an important consideration. In contrast, genetic testing for an adult onset hereditary cancer syndrome would not be performed in children, as it would not impact their medical management during childhood, and it removes the ability of them for them to make that autonomous decision about their own healthcare when they're adults. And those are the two guidelines that we wanted to highlight. And back over to Leslie.
Sorry. So this is essentially almost my last slide. I just wanted to have something that summed up some of the ethical and psychosocial issues. We've already discussed these as we've sort of gone through the talk mostly. Ray reviewed uncertain results and the power to predict that we typically say achieving a diagnosis will provide some prognostic information. As we are able to do this testing in a wider range of people, we're finding that this may not be as accurate as we thought it was when we could only test on a gene-by-gene basis, and we had clearer criteria on which to offer the testing in the first place. We've also talked a little bit about incidental or secondary findings, and some of our historically clear mandates about who we will and won't test and why may change as these newer treatments begin to emerge, and it's may change what we can, obviously, the utility may change. One of the things that has occurred to me is that some patients, when I'm calling out results and I perhaps find a negative result in one of these newer tests, have expressed relief and sort of happiness about the fact they don't have to change their image or their knowledge about their child. They see their child as a one-off, unique individual. And so I suppose I just thought it was worth bringing up something whereby perhaps there's been a promotion of the Diagnostic ODYSSEY in individuals, especially parents and families, accepting and adjusting to their child and their as they are. One of the perhaps ethical issues is around when we offer this testing in very fraught times. For example, in the neonatal period with a very sick infant, might this ability to make these diagnoses extremely rapidly interfere with parent-infant bonding, for example? And we did actually look, and there has been at least one paper on this issue on a qualitative basis. So I just wanted to finish with this slide. Maybe I'll leave it up and we can open the floor to any questions if there are questions from anybody at this point.
Well, thank you so much, Rachel and Leslie. There are no questions in the question box at this time, but I encourage you all to type your questions in the question section and we can address them. And if not, there may be I don't know how long your videos were, so there may be opportunity to show some of those.
Okay, there are a couple of minutes. Maybe should we show the first one, which is around Spinraza, which is the medication for spinal muscular atrophy. If I'm going to do that, do I need to change the presenter?
We'll do that here from our end.
Okay.
We're just setting up that video now. Just give us 5 seconds. That's a great video. Thank you for sharing. We do have a couple of questions in the question box, but I've lost my box. One second now. We're having some technical glitches here. There we go. How can we begin to get patients engaged? This is a question from, how can we begin to get patients engaged and involved as the technology continues to advance?
Ray, do you have something you'd like to say?
Sure, it's such a great question. I know that at least here in Calgary, we're looking at forming a rare disease advisory committee, which would consist of, not only patients with rare disease and or parents of patients with rare disease, but also clinicians, health ethicists, researchers. And so I wonder if just having sort of forums that come together on a regular basis where they have a mandate to focus on what's important to rare disease communities is one approach. Certainly leveraging social media and online platforms, such as some of the ones that we talked about, like Rare Disease Connect, is another strategy. I don't know, Leslie, if you have anything to add.
It's tricky. I'm wondering where the question, do we have any indication of where the questioner comes from to give us an idea of how we might be able to direct them what their resources might be locally and provincially?
I'll see if we get any comments back from the poster about that. And in the meantime, I can go on to the next question, which is, if a person is already diagnosed with a rare genetic disorder, is it possible to have multiple other rarities to be diagnosed? And I believe you commented on that during the presentation.
So just so that I understood, it's so hard with them just texting like this, you can't clarify. So a person who is healthy today, is it possible?
We can see if there's any comments, but the question doesn't specify. If you've already been diagnosed with a rare genetic disorder, can you still have other?
Yes, thank you. So having more than one rare disease is extra rare. There was a study that found that about 2% of patients specifically who were undergoing whole exome sequencing, so they'd already had sort of the standard array of testing and it hadn't found their underlying diagnosis. So that sort of implies that they're already maybe a little bit more complex, a little bit less recognizable. About 2% of those folks would have more than one diagnosis. Typically, these were patients who were either from, I shouldn't say typically, but there was an increased prevalence of patients from consanguineous families, so where patients were related, where the chance for there to be more than one genetic condition passed on is slightly increased, or patients, as I was sort of alluding to, who had complex presentation. But I would say, if the person who's asking that question has a rare disease diagnosis and that diagnosis seems to fit their symptoms, it's very unlikely that they have a second thing going on that we haven't found. Just empirically, that's unlikely. And there isn't any evidence in that person to suggest that we've missed something. In contrast, we are asked occasionally to meet with patients who already have a particular diagnosis. If they have features that don't really fit with that diagnosis, maybe it's because we don't fully understand that diagnosis, or maybe we've missed something more. So it sort of depends on the person's particular context. But in general, to answer the question, that's unusual.
Thank you. We're at the end of our time today, but I wanted to thank you, Rachel and Leslie, for a great presentation. And thank you to the audience for their questions. And Children's Healthcare Canada hosts our Spark Live webinars every Wednesday at 11 a.m. Eastern. It's always great if you watch live, as your questions and comments really enrich the discussion. But if you can't watch live, the recordings of these sessions are made available after the fact on our Knowledge Exchange Network. We're excited also about the next week's webinar, on March 11th, when we'll hear from Wendy Unger of the Hospital for Sick Children's Research Institute and the University of Toronto for Economic Evaluation in Child Health, Autism Spectrum Disorder. This webinar will be brought to you by the Child Bright Network, an innovative pan-Canadian network that aims to improve life outcomes for children with brain-based developmental disabilities and their families. If you have not already done so, please sign up for our Spark newsletter to stay up to date on all of our activities and events. So thanks again for joining us today. Thank you to Children's Healthcare Canada member Alberta Children's Hospital for supporting our webinar program, and hopefully we'll see many of you back here next week. Bye, everyone.